All right, well, welcome everyone to the 30th MFA conference. Wish we could be in person, but that's all right. My name is Camila Ferrandino, and the topic of this presentation is the effects of maternal exercise on fetal development. So quick background on me. I'm doing this completely independently and unaffiliated with any organization. I currently work for the City of Lakewood in Colorado, overseeing fitness and wellness programming for Parks and Recreation. I received my bachelor's in exercise science from Coastal Carolina University in Myrtle Beach, and my master's in applied physiology at the University of South Carolina at Columbia. So during my master's program, there were a lot of students looking at physical activity as a means to overcome childhood obesity in preschool age students. And I kind of had the thought, well, can exercise during pregnancy predispose a child to a healthier life? So I did some digging and found that it had been a pretty heavily talked about topic already, and decided to gather it all and do some further research into how exactly activity benefits a developing fetus. So just overview of our learning objectives. I'll just do a quick history of the research on exercise during pregnancy. Then we'll just go through a quick background on fetal development, the effects that maternal exercise and physical activity have on fetal development, and then the effects that exercise has on the mother and maternal diseases. And then we'll just finish off with how maternal exercise, what the recommendations have been and the guidelines for that as well. So, the history of exercise in pregnancy, obviously long ago, it was previously thought that bed rest was the most appropriate for pregnancy, and doctors typically discourage pregnant women from physical activity. A lot of thoughts that physical activity would jostle the baby in the womb. But in the 18th century, while maternal physical activity was viewed favorably and associated with easier labor and reduced fetal size, there were still a number of physical activity limitations that were suggested, such as the avoidance of dancing and horseback riding. The first scientific studies on the relationship between maternal physical activity and birth outcomes were published in the late 19th and early 20th centuries, and they focused on determinants of birth weight and attributed lower birth weights to increased levels of occupational and household physical activity. Then in the 1920s and 1930s, the prenatal exercise program was introduced in the United States with the goal of easing labor delivery and prescribed breathing patterns and physical activity for improving muscle tone, diminishing labor pain, improving fetal oxygenation, and facilitating postpartum weight loss. In 1949, the U.S. Children's Bureau issued a standard recommendation for prenatal physical activity, which said in the absence of maternal complications, pregnant women can continue housework, gardening, and daily walks up to about 1 mile, but they should avoid sports participation. Then in 1985, the American College of Obstetricians and Gynecologists issued the first guidelines for prenatal physical activity, but still advised caution with high-impact activities such as running, and included restrictions for duration, so no longer than 15 minutes, as well as heart rate limitations, so not letting your heart rate get past 140 beats per minute. Then they updated these in 2002. ACOG updated their guidelines and recommended about 30 minutes of moderate intensity physical activity during most days of the week for pregnancies without complications, and suggested that participating in a wide range of recreational physical activity is safe. But then there's been a call to further update these as well, since that was 18 years ago, and we still have some more information. And then in 2008, of course, the United States Department of Health and Human Services created the Physical Activity Guidelines for Americans, which included some guidelines for pregnancy as well. So the research that's been done, it's been gradually increased in the last few decades and opened up a world to more information about how exactly we can predispose a healthier fetus through exercise. But deeper research is hard to come by because of ethics violations. You can't really put a pregnant woman through a purposeful study. So mainly the research is retrospective, longitudinal, and animal studies. But of course, the issues with this is that we're relying on proper reporting by study participants and you're also comparing animal pregnancies to human pregnancies, which don't always align properly. All right, so the development of the fetus, just breaking it down into the first, second, and third trimesters. So normal gestation is about 38, 39 weeks. So the first trimester is where the major organs develop, such as the brain and spinal cord, lungs and trachea, the heart, the intestinal tract, and this is where the amniotic sac starts to form. In the second trimester, you have bones and joints starting to form, and this is when the fetus begins to breathe in the amniotic fluid. And this period is especially important for the length of the fetus. And then in the third trimester, you have some major nerve tracts forming in the brain. The bones start to grow and harden, and this is when the lungs complete development. And the third trimester is especially important for the weight of the fetus. So here's our placental mechanism. So the placenta is an organ that develops in the uterus during pregnancy. It provides oxygen and nutrients to the growing baby and removes waste products from the baby's blood. Also helps with thermoregulation, gas exchange via the mother's blood supply, and helps against internal infection, and also produces hormones that support pregnancy. So during pregnancy, maternal blood flow is primarily directed to the uterus and placenta to supply the fetus with essential nutrients, particularly glucose to be for uptake to the brain. When exercise is initiated in pregnancy, blood flow is redirected to active skeletal muscle, which decreases blood flow to the uterus, placenta, and umbilicus, which results in a reduction of oxygen delivery and may cause fetal hypoxia. However, there's been no evidence of increased risk of fetal hypoxia during maternal exercise due to the initiation of materno-fetal protective mechanisms in these situations. And we'll kind of go over this in the next slide as well, but as a result of acute exercise, the fetus will initiate a sympathetic response to increase heart rate and propel oxygen through the body to avoid any decreases in PO2, or oxygen tension. So over time, the chronic fall in maternal PO2 from exercise may stimulate angiogenesis and the formation of new villi in the placenta, which increases oxygen uptake by the fetus. So you have your villi here in the picture on the right, which help with the transfer of nutrients via blood from mother to fetus. So in an undernourished fetal connection in the placenta, the fetus will go into a catabolic state and use its own substrates for energy. It'll also divert blood flow away from the liver and abdominal viscera to support more vital organs, such as the heart and the brain. So just kind of reiterating what we just talked about, during exercise, blood flow is diverted away from the uterus to active skeletal muscle. The fetus will increase its heart rate as a compensatory mechanism. This is acute bouts of exercise, of course, but the chronic fall in maternal PO2 stimulates angiogenesis and the formation of the villus tree, which is typically stimulated most in early pregnancy, so about 20 to 26 weeks gestation, which suggests that exercise during early pregnancy is most important. So you have this chart on the right here. You have these dashed arrows that represent fetal, placental, and maternal adaptations that occur in a low-risk pregnancy, and they counterbalance potential maternal exercise effects like hypoglycemia, decreased uterine blood flow, and increased body temperature. So the fetus and the placenta will adapt to these changes, which ultimately benefit the fetus in the end and help support increased blood flow to the placenta, which increases nutrition to the fetus. So, as discussed before, adequate placental development is necessary for proper fetal growth. So there are multiple studies observing the effects of maternal exercise on placental function, and so far there's no evidence suggesting that exercise may negatively impact placental growth. So they typically find higher placental weight or volume in women who exercise during pregnancy, which means that that's increased nutrient delivery, which enhances fetal growth in the end. A lot of studies finding that weight-bearing exercises increase placental volume, growth, vascularity, and surface area in early pregnancy. So higher placental weight can be directly related to increased blood flow to the fetus, and therefore would suggest it has a more nutritive effect than a placenta of lesser weight. So in a study in 2006, they had a couple of different groups. They exercised 30 minutes per day, 3 days a week, one until term, one that stopped at 20 weeks gestation, and then they had a control group that was sedentary. This is all, of course, as the mother's choosing. And they showed that exercise 30 minutes per day, 3 days a week, showed an increase in fractional volume of parenchymal tissue and enhanced vascular and villus growth in the placenta. Of course, there were still these benefits shown in women that stopped exercising after 20 weeks gestation, but there were more benefits shown if women exercised through to term. So some cardiovascular effects in the fetus during exercise, not too much here. The chart at the top here, the blue line at the top is going to represent your fetal heart rate. The red line at the bottom is going to represent the maternal heart rate. Fetal heart rate is used to determine fetal well-being and distress, and also can show signs of hypoxia through tachycardia, rate accelerations and decelerations. But the fetal heart rate is usually much higher in the first and second trimester, and then slows down to about an average of 140 beats per minute in the third trimester. Tachycardia is the most common fetal heart rate response seen after an acute bout of exercise, but it's still really only seen in about 9% of pregnancies. So after sustained maternal exercise, the fetus will sense a decrease in blood flow and oxygen delivery, and will reciprocate by stimulating the sympathetic system to increase the heart rate. So they actually have seen a reduction in the prevalence of fetal tachycardia in chronically exercised mothers. So of course there's going to be an increase in fetal heart rate after an acute bout of exercise, but overall tachycardia has been seen less in those the fetuses of chronically exercised mothers. And also acute tachycardia has been found not to be harmful for the fetus, and is actually an indicator of a minimal reduction in fetal oxygen tension, and is not detrimental to fetal well-being. However, fetal bradycardia could be very detrimental to a fetus. It's a reflexive vagal response within the parasympathetic nervous system that results from maternal hypotension and protects the fetus against reduced placental blood flow. So it slows the heart rate down to protect vital organs. And this restricts growth, of course, in utero. So fetal bradycardia has been observed in pregnant mothers who have exercised acutely, but who are mostly sedentary during pregnancy. So this stresses the importance of continuing exercise throughout pregnancy and keeping up with a regular regimen. So fetal neurodevelopment during pregnancy is a fairly new topic within maternal exercise research, but it's become an increasingly vital interest in pregnant women. So if fetal brain development and function can be enhanced through maternal exercise, this could result in increased mental capacity and reducing the risk or severity of psychiatric illnesses later on in childhood and possibly adulthood. So the concerns here with exercise during pregnancy is that there's an increase in maternal body temperature, creating a hyperthermic environment, which can cause some fetal malformations such as neural tube defects and negatively affect cell division. And the HSP70, which is a heat shock protein responsible for regulating cellular stress, has been found reduced in fetuses sensitive to hyperthermia. So a major concern here. But a couple of studies have found that exercise diminishes oxidative damage or tissue damage by upregulating this heat shock protein in both human and animal studies. So a 2011 study showed that fetuses exposed to hypothermic conditions alone had a reduced chance of survival when compared to a control group that were not in hypothermic conditions. So this is just hypothermic conditions alone. And they had a 59.2% chance survival compared to 100% chance survival. But when exercise was introduced to that hypothermic environment, that 59.2% chance of survival increased to 75.2% survival. So neural tube formation was also normal between control, the exercise group, and the exercise and hypothermic groups, but neural tube formation was abnormal in the hypothermic group alone. So this suggests that exercise can have a reversal effect on hypothermic conditions. So BDNF is a pretty big topic too with neurodevelopment in the fetus. BDNF is the brain-derived neurotrophic factor, which is responsible for neurotransmitter turnover, neuritegenesis, neuronal survival, and stimulates long-term potentiation through enhanced synaptic transmissions and neuroplasticity. So most studies have found increased levels of BDNF in fetuses of exercised mothers. It has a positive effect on the hippocampus, which translates into increased central nervous system function. So a 2007 study found increased BDNF mRNA expression in rats. They had two groups, one treadmill running and swimming, and then they had a control group as well. So that's our chart here on the right. So they found that in both the treadmill and swimming studies, BDNF mRNA expression was higher in the offspring of rats who exercised during pregnancy compared to those born from sedentary mothers. They found an increase in spatial learning and short-term memory in the exercise group's offspring compared to control. This suggests that enhanced cognitive function was a result of synaptic transmission from maternal exercise. So if we look at this chart here on the right, BRDU is responsible for DNA synthesis and proliferating cells, which pretty much shows increased neurogenesis. So the running group had significantly higher expression of these cells. So if you look at A and B, you're looking at the darker cells, which we have more of in B, which is the running and exercised group. Pretty cool. So then we're talking about long-term neural effects. So researchers followed a group of women or the offspring of women who were sedentary during pregnancy and those who exercised. So this was a study done in 2003. So immediately following birth, infants born to exercise mothers had improved attentiveness and behavioral control compared to sedentary mothers' infants, and they were easier to soothe and cried less. And then at age 5, they had enhanced neurodevelopment and were cognitively ahead of children the same age. And this study aims to also reevaluate these children at the age of 18. So those results should be hopefully coming out soon. If it was 2003, which would be interesting to see how these long-term effects stay. All right, so talking about growth rates now. So we'll start with low birth weight. Birth weight is a critical determinant of health. Researchers have found that the majority of the body's functions, including cardiovascular, respiratory, immune, hepatic, and nervous systems, are all negatively affected by low birth weight. And premature infants and low birth weight babies are major concerns for expecting mothers. So small for gestational age and low birth weight is defined as a birth weight less than 5.5 pounds, and it's associated with intrauterine growth restriction, so lack of blood flow essentially between the placenta and the developing fetus. Common issues associated with low birth weight are perinatal death, fetal distress, meconium aspiration system, polycythemia, fetal hypothermia. So 2/3 of all low birth weight are preterm babies, which means that that's less than 37 weeks gestation. They don't have the full time to develop. In the US, 12% of all births are preterm, which has gone up about 1 to 2% in the last few years. The world average is about 5 to 7%. So 15 to 25% of preterm births occur because of pregnancy complications and typically result in handicaps of the infant. So going over a couple of issues that arise out of low birth weight and intrauterine growth restriction. So some cardiovascular issues. There's been a strong association observed between thinness at birth and lower placental weight, along with increased risk of cardiovascular disease. So there's been evidence that show men and women whose birth weights were in the lower percentile had increased rates of coronary heart disease. So since the infants are smaller than normal at birth, their bodies must undergo a rapid catch-up phase later in childhood, which has been shown to increase the risk of coronary heart disease. So the mechanism they think behind this, of course, there's increased risk of hypertension. So when you have intrauterine growth restriction, there's a diversion of blood flow away from the kidneys to support more important organ function like the brain and the heart. The kidneys of both low birth weight infants and hypertensive adults show significantly lower glomeruli per kidney and fewer nephrons than control groups that had normal blood pressure. So an increase in birth weight shows a reflective decrease in blood pressure in childhood and adulthood. So low birth weight is not great for risk of coronary heart disease and heart defects later in life. Type 2 diabetes is also has an increased prevalence in those who are low birth weight. In adult men and women who weighed less than 5.5 pounds at birth, the prevalence of type 2 diabetes was higher compared to those who weighed more. This is thought to be because of fetal undernutrition, programs insulin resistance, since the fetus has to conserve that glucose concentration for brain development. The effects of low birth weight on the fetal respiratory system have not been fully evaluated in human trials, but animal studies have shown the evidence of altered lung development in intrauterine growth restricted fetuses on low birth weight offspring. So a couple of other issues there with impaired ventilator efficiency and increased prevalence of bronchial asthma. And then the immune function is also distorted for low birth weight infants. Small for gestational age infants have exhibited atrophy of the thymus, impaired cell-mediated immunity, and some immune deficiency diseases, suggesting that their immune system did not properly develop because of lack of growth during gestation. Also, mechanism behind this is thought to be that due to protein malnutrition, this leads to diminution of the thymus and decreased lymphoid cells in the spleen and lymph nodes. And then lastly, low birth weight also affects psychiatric health. It's important for daily functioning in life, but can be compromised during early development. So there's a significant association found between men and women who either committed suicide or were depressive or schizophrenic, and low birth weights or low rates of weight gain in infancy. So the possibility of the effect of low birth weight on the development of psychiatric illnesses is thought to be related to the dysfunction of the hypothalamic pituitary adrenal, or the HPA axis. So low birth weight babies also have a negative impact on the HPA axis, with research showing that subjects born before 39 weeks gestation have unbalanced cortisol concentrations, which suggests that both hyper and hypocortisolism may be consequences of impaired HPA axis programming in utero during development. So there's a demand for further research in this field, as inhibition of proper fetal development of the HPA axis could have major negative effects on multiple systems of the body. So a lot of problems there with low birth weight. So how can maternal exercise prevent intrauterine growth restriction? So women who exercised during pregnancy were half as likely to deliver premature babies than sedentary mothers. They also found that women who expended more than 1,000 kilocalories per week via physical activity reduced their risk of spontaneous preterm births. And this was also seen in women who had previous pregnancy issues or experienced first trimester bleeding during current pregnancy, which first trimester bleeding is an indication of fetal demise or miscarriage. Also, recreational athletes who participate in strenuous exercise through term also showed a lowered risk in preterm births compared to sedentary controls, and only experienced a very small reduction in gestational age, less than a week. So this suggests that exercise helps to push delivery past 37 weeks, and also stimulates a more timely delivery through increased muscle tone, more efficient immunological responses, and increased fetal size. Now, on the other end of that is macrosomia, which is defined as a birth weight of over 9.9 pounds. A lot of issues with macrosomia later in life, with shoulder dystocia from labor, brachial plexus injury, certain types of cancer, higher prevalence of type 2 diabetes later in life, and also just increased risk of mortality. So the mechanisms thought behind this, why exercise can help with the risk of developing a macrosomic baby, of birthing a macrosomic baby, is that fetal fat is programmed in the last 8 to 10 weeks of gestation. So it's thought that regular exercise in the third trimester contributes most to this. So babies that are born from exercise mothers are 300 grams less than those of sedentary mothers, but this isn't necessarily due to decreases in like brain tissue and saying that the placenta weighs less or anything. It's simply that these babies have less fetal fat. So early longitudinal research has actually shown that leaner babies with less fetal fat are more neurologically advanced than controls by age 5. So that's it on how exercise directly affects the fetus itself, and some of the information behind that. So now we're going to transition over into some of the maternal diseases and how exercise benefits the mother, which is thereby going to affect the baby. So we'll go over a couple of different complications here, but exercise has decreased, it's been shown to decrease the odds of having a major pregnancy complication by about 40%. So we're going to talk about PCOS, gestational diabetes, preeclampsia, and anxiety and depression. And of course, on the right here, it just shows some other benefits: reduced risk of macrosomia, which we just talked about, reduced risk of preterm delivery, better labor, reduced labor pains, reduced risk of gestational hypertension, all that fun stuff. And also, based on the dose response curves, the recommendation of 150 minutes per week of moderate rate intensity physical activity is also associated with at least a 25% reduction in the odds of developing each of preeclampsia, gestational hypertension, gestational diabetes, excessive weight gain, and reduces the severity of depressive symptoms. So PCOS is polycystic ovarian syndrome. It's a hormonal condition that affects between 6 and 15% of women of childbearing age. Usually has to do with chronic anovulation, hyperandrogenism, and insulin resistance. If you're diagnosed with PCOS, it may become more difficult to get pregnant. And if you're able to become pregnant, you're at risk for more complications during pregnancy, labor, and delivery. So women with PCOS are 3 times more likely to have a miscarriage as compared to women who don't have PCOS. Also more likely to develop preeclampsia, gestational diabetes, and have a larger baby in premature delivery, which could lead to difficulty during delivery or cesarean delivery. And like we said, we have a higher chance of developing insulin resistance, hypertension, depression, and anxiety. So infants born to women with PCOS typically have an increased rate of admission to the NICU, higher prevalence of becoming low birth weight infants, or a higher chance of perinatal mortality or premature. So the 2007 study observed the effects of exercise on the treatment of PCOS in 90 women with the disease through a 3-month structured exercise program. So women who participate in 30 minutes of cycling at 60 to 70% VO2 max for 3 days a week. These women, after 3 months, only the exercise PCOS patients showed significant improvements in BMI, waist circumference, waist to hip ratio, and fasting insulin, along with increased cardiopulmonary functional capacity and insulin sensitivity compared to the sedentary controls. A second study conducted a similar experiment, but they added 60 minutes of light resistance training to the exercise program on top of that aerobic training. And they found analogous results, along with a tendency toward improved sex hormones. So gestational diabetes, although there are a few studies that observe the effects of maternal exercise on the treatment or prevention of gestational diabetes, the overall findings indicate that maternal exercise may reduce the risk of the development of gestational diabetes and protect against any consequences of gestational diabetes on the fetus. So gestational diabetes is development of insulin resistance during pregnancy. So this doesn't necessarily mean that you have to have diabetes before pregnancy. So your fasting blood glucose levels are greater than 93. Fetuses born to mothers with gestational diabetes have a higher rate of obesity and risk of type 2 diabetes later on in life, and also an increased risk of maternal and perinatal morbidity and perinatal mortality. So a couple studies, a case control study of 155 women with gestational diabetes and 386 controls found a 50% decrease in the risk of gestational diabetes with women who participated in leisure time physical activity, while a second cohort study found a 44% reduced risk in gestational diabetes in women who participate in vigorous physical activity during pregnancy. So of course, the reduction in risk was increased when women were physically active before and during pregnancy, but there's still a large significance of maternal exercise alone on treatment and prevention of gestational diabetes throughout the literature. So just a few charts here showing the offspring glucose tolerance, insulin, fat mass, and body weight. So a couple different groups here. So you have your solid white bar, which is a sedentary group. The black bar is a trained group. So this is the mothers that were training during pregnancy. And then the vertical stripes are those mothers that were training before pregnancy as well. And then the horizontal stripes are those who are only exercising during gestation. So obviously significant improvements in fat mass, glucose tolerance, insulin, and body weight in the exercised group. And then some further improvements for those who are training during gestation compared to those who are also training pre-pregnancy. So preeclampsia. Preeclampsia refers to the condition talking about endothelial dysfunction, increased systemic inflammatory response, and kidney and liver dysfunction, as well as hypertension. It's the second leading cause of death during pregnancy and delivery. It's associated with an increased risk of perinatal morbidity and mortality. So in previous case control studies, women with preeclampsia who participated in regular physical activity during early pregnancy reduced the risk of preeclampsia by 35% compared to women who were sedentary. And then another analysis had shown a 68% decrease in the risk of preeclampsia in women who participated in at least 3 to 6 hours of leisure time physical activity throughout the first 20 weeks gestation. So prior research has also demonstrated an inverse relationship between preeclampsia risk and exercise intensity and caloric expenditure during pregnancy. So once again, talking about those first 20 weeks of gestation, stressing that exercise during early pregnancy is most effective for helping with the risks and symptoms of preeclampsia. Let's talk a little bit about obesity. So according to a 2013 survey, 70% of women were incorrect about proper gestational weight gain, with 54% of those women guessing above the recommended range. And maternal obesity has been suggested as a primary mechanism for predisposing the fetus to later diseases in life, such as metabolic syndrome and cardiovascular dysfunction. So recommended amount of gestational weight gain for women who are healthy weight before pregnancy is about 25 to 35 pounds. Women who have a BMI of over 30 recommended is about 11 to 25 pounds. So women who are obese during pregnancy are twice as likely to have stillbirths compared to women of healthy weight and are more likely to give birth to macrosomic babies than controls. Also, preterm births are more common in obese mothers than mothers of a healthy weight, and admission of infants to the NICU has shown a higher prevalence in obese pregnancy compared to lean mothers. Maternal obesity has also been shown to increase risk for maternal diseases such as preeclampsia, PCOS, and gestational diabetes that can further result in adverse fetal development outcomes. So infants born from obese mothers are also at risk for negative conditions themselves, such as childhood obesity, neural tube defects, heart wall defects, cephalopelvic disproportions, and multiple congenital anomaly syndromes. Woo. So these findings suggest maternal obesity may play a role in fetal programming. A couple studies, in studies where an exercise intervention was introduced to pregnant women, overweight sedentary women gained 10 pounds more than women who participated in regular exercise throughout pregnancy. Infants born to the exercise mothers had less complications during delivery and showed fewer signs of fetal distress compared to sedentary obese mothers. Obese mothers in the study also had higher incidence of giving birth to infants with low 5-minute APGAR score. So APGAR is appearance, pulse, grimace, activity, and respiration. And also higher incidence of seizure hypoglycemia, polycythemia, once again, meconium aspiration syndrome. So another chart here just showing how maternal obesity can affect pregnancy and even preconception, and also issues later in life, postpartum. So the solid boxes are all issues that can arise from obesity. And then the dashed boxes are all things, outcomes that can happen from weight loss prior to conception or exercise during pregnancy. So we can see that exercise can prevent maternal fetal disease, prevents excessive weight gain, which causes other issues later in life like metabolic syndrome, diabetes, so on and so forth. For maternal anxiety, it's a common psychological disorder seen in women throughout pregnancy. Typically stems from stresses such as unwanted physical alterations, fluctuating hormones, and concerns over development of the fetus or painful labor. Stress causes an increase in plasma concentrations of hormones such as cortisol, ACTH, cortico-releasing hormone, and noradrenaline, which can be directly transferred to the fetus via placental blood flow. So excess concentrations of these hormones can actually be harmful to the fetus in terms of growth and development. In a case control study from 1994, they actually found similar effects of smoking on fetal development that were seen in fetuses of women who had high anxiety levels during pregnancy. So once again, the mechanism behind this is thought to be restricted uterine blood flow due to the increase in plasma noradrenaline from activation of the HPA axis and the sympathetic nervous system. There's actually a large amount of women, about 70% of women, pregnant women, are diagnosed with depression and anxiety. So restricted uterine blood flow stemming from the increase in plasma noradrenaline leads to low birth weight or preterm babies and subsequent fetal malformations. So studies observing pregnant women with high anxiety levels show this impaired uterine blood flow, and pretty much high anxiety is thought to be responsible for these decreases. So reduced uterine blood flow has been shown to cause intrauterine growth restriction of the fetus, resulting in your low birth weight or preterm babies. There's also an increased risk of spontaneous abortion in anxious or stressed mothers, especially when anxiety levels are high during the first trimester. So the first trimester is actually thought to be specifically important for reduction in anxiety, as mothers who experience the highest stress after 4 months gestation did not experience the same adverse neonatal outcomes as mothers who were stressed in the first 3 months of pregnancy. So once again, that first trimester being specifically important for development of the fetus. High anxiety scores have been shown to permanently impact neural outcomes of the infant later in life. So this is a longitudinal study. Infants born to highly anxious mothers were more difficult to soothe and cried 2 to 3 days after birth, cried more 2 to 3 days after birth compared to infants born from low anxiety mothers. Exposure to prenatal anxiety has been associated with higher incidence of cognitive and behavioral disorders such as ADHD, schizophrenia, and depression. The same offspring demonstrated delayed motor development and decreased spatial memory when later compared to those of the same age. So in another study following children from the first trimester of pregnancy up to 9 years of age, researchers monitored specific neurodevelopmental characteristics of those born to highly anxious mothers, and during intrauterine development, the fetuses displayed more activity than controls. So that was inside the womb. And then after 7 months postnatal, the infants cried more, were more irritable, had irregular biological functions, and had more difficult temperaments. Then after 9 years, the children were still more active than other children and had more attention deficits and were more aggressive. So it's been suggested that the excessive release of the stress hormone corticosterone by the anxious mother is partly responsible for these neural impairments seen in the offspring, as corticosterone is known to limit hippocampal neurogenesis, which impairs learning ability, spatial memory, and psychomotor capability. So then another explanation to these cognitive defects is the restriction of placental blood flow, which can cause cranial malformations and reduced brain growth, which further damages fetal neurodevelopment. So how can exercise mitigate the effects of anxiety during pregnancy? So exercise has profound effects on the brain and can reduce anxiety and stress levels in both acute and chronic fashions. The optimal amount and even mode of exercise is still not quite clear, but studies have shown those with higher physical activity levels exhibit fewer health issues when encountered with stress. So with withdrawal, on the other side of that, withdrawal of exercise has been shown to increase negative cognitive symptoms such as bad mood, fatigue, and depression, while even low physical activity during pregnancy has been associated with anxiety, depression, and fatigue as well. So women who exercise during pregnancy have reported more positive moods through gestation, and their offspring have shown higher levels of BDNF and IGF-1, its growth factor, compared to sedentary or low activity mothers. So a few possible mechanisms that underlie the effect exercise has on anxiety and stress levels are the regulation of the HPA axis again, and control of the stress hormone concentrations. So as mentioned previously, exercise during pregnancy also alleviates most physical symptoms experienced by the mother during gestation, such as trouble sleeping, back pain, and mood and self-image. So limits the release of those stress hormones. So overall, just a diagram kind of reviewing the impacts of undernutrition and overnutrition on the fetus and the mother. So later on in life, if you have an undernutrition of the fetus and placenta, you're going to have issues such as higher stress levels, preeclampsia. Those can all lead to undernutrition, which then lead to a small gestational age or preterm baby, which leads to further disease risks, type 1 diabetes. And then you have overnutrition due to insulin resistance, obesity, or type 2 diabetes, which can lead to a macrosomic baby or large for gestational age, can affect fertility for the baby, metabolic syndrome, cardiovascular disease, and obesity later in life. So you want to kind of stick to the middle here with a healthy, normal weight and balanced diet. So now we're just going to go over timing, type, volume, and intensity. So as we've discussed many times, exercise during early pregnancy is important for the initiation of that maternal-fetal blood flow connection, sufficient organogenesis, placental growth, and also helps to increase placental volume. Since we talked about that 20 weeks gestation, really stimulating the villus tree, because you have growth of larger diameter placental villi stimulated in those early weeks of pregnancy. So women who discontinued exercise after 20 weeks gestation still had higher placental volume compared to sedentary, but they didn't see as many benefits or as high placental volume as those who exercised until term. So while exercise during early pregnancy is important, it's still important to exercise through the term. Of course, if you're not previously active prior to pregnancy, women should talk with their doctor and gradually add in physical activity, looking to increase the volume. While they've seen that increasing the volume of exercise during early pregnancy has a positive influence on the functional capacity of placenta, which can increase placental blood flow and nutrient delivery, which helps with fetal development. And then sustained weight-bearing activities that range from moderate to high intensity have a positive influence on fetal placental growth, but should be reserved more for the earlier stages of pregnancy. But this also depends on the mother's previous activity levels. An elite athlete would probably continue training the way that they would and maybe slow down a little bit towards the end of pregnancy, mainly because the body can't handle the same intensities. But like I said, it depends on the mother's physical activity levels before pregnancy. They found that women that changed their exercise programs from low intensity to high intensity in the last 2/3 of pregnancy showed slower fetal placental growth compared to those who went from high to low. So this is saying that you started off at a lower intensity early on in pregnancy and then got higher intensity towards the end. So this showed so that reduced fetal placental growth rates. So if you decrease intensity and volume of the training during late pregnancy, that can improve growth rate in normal pregnancies and also pregnancies at risk for intrauterine growth restriction. So women who exercised at 300 minutes per week during late gestation still gave birth to leaner infants and gained less gestational weight. So continue to exercise through the term, but maybe decreasing intensity slightly towards the end of that instead of going from low to high. So not so much research done on too much on mode. There's been little negative effects seen between resistance and aerobic training. Some women feel that aerobic training could jostle the fetus like running or jogging, but there's little evidence suggesting that. Studies that use running or swimming for exercise protocol show it can stimulate placental growth, volume, and placental function, as well as reduce fetal fat mass and increase fetal lean mass. So in a study of 11 runners, so these are all women who are running before pregnancy, they continued their training 40 to 60 minute sessions for 4 days a week at 55 to 65% VO2 max throughout pregnancy. Found that it's beneficial to the placenta, increases placental volume and vascularity. However, swimming may be more beneficial than running because it is low impact and not necessarily jostling the fetus, but it doesn't increase fetal heart rate or maternal body temperature to the same degree as higher impact activities. So other studies suggest to stay away from activities that could increase physical harm to the mother, such as falling or physical contact, and then also avoiding exercise in extreme heat or high humidity, such as hot yoga, because of concerns about dehydration, or activities such as scuba diving with high pressure or high altitude for those living at sea level. So there's been little research on resistance training, but ACSM recommends that women avoid heavy lifting or straining exercise during the second and third trimester. This is, of course, if you're not already a power lifter before pregnancy. This is due to concerns over blood pressure and hypertension. But some studies show no adverse effects of weightlifting, but show lower prevalence of macrosomic babies in exercise resistance exercise groups compared to sedentary groups. So just reviewing some of the current guidelines. This is mainly from the ACOG, American College of Obstetricians and Gynecologists. So avoiding or modifying exercises in prone or supine position after first trimester, avoiding programs that exceed pre-pregnancy intensities or extremely exceeding pre-pregnancy intensities. So if not previously active before pregnancy, just gradually adding in that exercise. The ACOG recommends any activities that improve cardiorespiratory and musculoskeletal function, suggesting low weight and high repetition for strength training. Also, flexibility training is super important to maintain joint range of motion, since this can improve the laxity of ligaments during pregnancy, since ligaments can become super stiff. And in terms of intensity, maintaining an exercise program at about 3 to 4 METs, 50 to 60% VO2 max, 60 to 70% heart rate max, or 12 to 14 RPE on the Borg scale. And of course, physical activity for 30 minutes on most, if not all days of the week, similar to what they are for regular adults. Unless previously sedentary, then women should accumulate activity in 15-minute increments and gradually progress to 30 increments. So emphasizing that some is better than none, suggesting that incorporating even minimal amounts of physical activity can be beneficial, even if it's just 10 minutes of walking per day. It's actually been shown to reduce the risk of developing preeclampsia by 25%, just 10 minutes of walking a day. So according to 2019 Canadian guidelines for physical activity throughout pregnancy, all women without medical restrictions should be physically active throughout pregnancy. Of course, there are some absolute contraindications where moderate to vigorous physical activity should be avoided because of adverse outcomes for the mother and fetus. Those typically include pre-existing cardiovascular or respiratory diseases, but in these scenarios, activities of daily living may be encouraged by the healthcare provider. So overall, that's what we've got. I hope that you guys enjoyed the presentation and the effects that exercise can have on the fetus. I have a couple of references and resources here for everyone. There's a whole bunch here, but really great information out there. But thank you everyone for attending this conference and for watching my presentation.